Welcome. My name is Darshan Mehta. I'm the Education and Medical Director for the Osher Center for Integrative Health, and it's really my delight to have you here this morning for our February Grand Rounds. Just as a reminder, if you would like CME credit, please email to hmsoshercenter@bwh.harvard.edu and just include your full name, your degree, email address, and today's date for the Grand Rounds. As many of you know, we host an integrative medicine network forum every 2 years. And this year, we will be holding it on December 9th and 10th. It's intersecting high-tech medicine with soft touch healing, exploring the emerging interface between technology and integrative health. And again, this will be held at the Harvard Medical School Martin Conference Center, and we will also be live streaming it as well. Sign up to get updates, but again, save the day. We look forward to having you there. More details will be forthcoming. Our next Grand Rounds will be led by Dr. Beth Frades, and it's going to be the title, The Power of Lifestyle Medicine for Patients and Providers. This will be on Tuesday, March 5th at 8 a.m. Again, it's be virtual, and there's the QR code. And again, look forward to having you there as well. So with that, it's really my pleasure to introduce my colleague and friend, Dr. Julia Loewenthal. She's an internal medicine physician and geriatrician at Brigham Women's Hospital and instructor in medicine, Harvard Medical School. She's also the assistant program director for the internal medicine residency program here. Dr. Loewenthal is also part of our Osher Center, and leads and has created and led the geriatric integrative medicine program at the Osher Center for Integrative Health. She has done tremendous work, scholarly work in medical education, healthy aging, yoga, and healthcare provider well-being. So with that, I will turn it over to Julia, who will introduce the rest of the panel.
Thank you. I'll just set up my slides. So thank you so much for this opportunity to present on integrative approaches to long COVID, a clinical case. So we are joined by an all-star lineup of speakers today. Most importantly, I want to introduce Marvin Davidson, who we'll hear from in a little bit. And he's our patient who's graciously volunteered, not only his clinical case, but also a lot of time in preparation for this presentation. So we just wanted to start off by thanking Marvin. We're really excited to hear from you later in the talk. I also would like to introduce Dr. Kimberly Parks, another key part of this talk as we were putting it together. She's the founder and medical director of Synergy Private Health and Integrative Medical Practice in Chestnut Hill, as well as a staff cardiologist at Massachusetts General Hospital. We are also joined by Dr. Kyle Harrold, a neurologist specializing in neuroinfectious diseases and neuroimmunology at both Brigham and Women's Hospital and Massachusetts General. He sees patients with post-acute sequelae of COVID-19 in the Brigham Recovery Clinic. And also Katie Walker, an acupuncturist at the Osher Clinical Center and a research acupuncturist at Massachusetts General Hospital. The speakers today have no relevant disclosures to report. So we're hoping by the end of this talk, our audience will be able to begin to understand the patient experience of living with long COVID. We also hope to define long COVID in its various clinical presentations as we understand it to date, understand an initial diagnostic and management strategy, and also appreciate the role of several integrative therapies for long COVID. And for this talk in particular, we'll highlight the role of acupuncture and cold exposure, which were really integral to Marvin's recovery process. So now I'd like to go ahead and turn it over to Dr. Kimberly Parks to take it away for the rest of this segment.
Thank you, Dr. Loewenthal. It's such a pleasure to be with you all here this morning. And thank you to the audience for taking time out of your busy morning to learn with us. And I'm especially privileged to be here with our patient, Marvin, whom I met 2 years ago and have had the pleasure of working with. So let's start with his history. At the time that I met Marvin, he was 66 years old. He was pretty active, really had no significant medical history other than pelvic pain syndrome that was quiescent, well controlled with treatment. He lives in Newton. He's married. He's a retired engineer and also residential contractor. No history of substance use. And importantly, he was a former competitive cyclist and personal trainer and really did heavy physical labor with his occupation. So it kind of gives you a sense of his physical state at the time that I met him or just prior to meeting him. While he was in good health until January, on January 7th, he developed COVID-19. At that time, the Omicron and Delta variants were prominent. He had been vaccinated. He will say, he was sort of first in line to get each of those vaccinations and was doing a really good job isolating for the most part. And his initial course began with typical upper respiratory infection symptoms. And he had a very slow recovery from that until early March, at which time his symptoms started to shift and he was having lightheadedness, which he noted was worse in the morning and was worse from sitting to standing. He was having headaches, tingling in his arms, a myriad of neuropathic symptoms, and he had heightened anxiety, which was new for him. He sought care from his medical team and had a number of tests. He had a stress echo, he had pulmonary function testing. He didn't have any formal orthostatic measurements or tilt testing. All the testing that he had was negative. And then he's very health literate and had been exploring his symptoms online and thought, it really sounds like I have autonomic insufficiency, and had spoken with a neighbor who happened to be a colleague of mine, and thankfully we were connected for further evaluation. Now, when I first met him, I actually was on isolation. So we were communicating virtually, and I wasn't able to do a full physical exam, but he did come into the office to meet with one of our staff who performed orthostatic blood pressure measurements, because his big question was, do I have POTS syndrome? Do I have orthostasis? Do I have autonomic insufficiency? And so, when we think about autonomic insufficiency or orthostasis, the first test is just to simply take measurements in the office. And we do that by initially taking a blood pressure while a person is supine. We let them lie for 5 minutes and take a baseline. And then we repeat that after the person is standing, after 1 minute, after 3 minutes, and sometimes after 5 minutes. And that's pretty standard in the office. And as you can see, his blood pressure went from 118 to a low of 112 after 3 minutes of standing. That does not meet criteria for orthostasis. We want to see a drop in the systolic blood pressure of 20 millimeters of mercury, or a drop in the diastolic blood pressure of 10 millimeters of mercury to meet criteria. And also, if you look on the right of the screen is the heart rate. And one of the things we were wondering is, does he have POTS syndrome or postural orthostatic tachycardia syndrome? And that criteria would be met if there is an increase in heart rate of 30 beats per minute. Now, Marvin knew, well, I really think I have this orthostasis, and my symptoms are pretty consistent with it. He took it upon himself to do some home testing. He had a blood pressure cuff, and I will draw your attention to the photo here, and you can see on the x-axis, he plots out time in minutes. I did point out that he is an engineer, so he was able to do this beautifully for us. And on the y-axis, you see is his blood pressure and heart rate. And he begins with a supine measurement, which was 113/71. And he was patient enough to wait it out until he began having symptoms. And that occurred around the 25th minute. And you can see by the time he is standing for 25 minutes, his systolic blood pressure has now dropped from 113 to 88 millimeters of mercury. And his diastolic blood pressure has dropped from 71 to 61. So he meets criteria of orthostasis based on both blood pressure readings. Again, notably, his heart rate did not increase, and he did not meet criteria for POTS syndrome. Now, one critical piece here I want to point out is that as providers, doing that orthostatic measurement is pretty typical, and often, someone presents with symptoms that are suggestive of autonomic insufficiency. We sort of do that test and say, oh, doesn't meet criteria, something else must be going on. But what I want to point out is that data show that only about 40% of patients test positive after 10 minutes. And so if you suspect that someone has autonomic insufficiency in your office, the standard measurements for orthostasis is not enough, and they need to get additional testing. Now, to go back to the timeline of symptoms, just to summarize here, in January of 2022, he developed the COVID-19 infection. He had received his timely initial vaccines and received the booster. And then his symptoms, and his initial symptoms consisting of upper respiratory infection symptoms had resolved. And then he was left with this myriad of other symptoms, the lightheadedness, tingling, headache, also very prominent ringing in the ears, tinnitus, some heat sensitivity. And I also want to point out he had what has been described as post-exertional malaise that plagues a lot of people post-COVID. And that was a very prominent symptom for him and quite debilitating. As I pointed out, he was a very active man. And so, for him, he would do a short burst of activity, and it would feel as though he ran a marathon, when in fact he only might have climbed a couple flights of stairs. In the spring of 2022, he did seek treatment. There was no formal diagnosis made. He tried a number of things to help with his symptoms. He was started on an SSRI, started on a high salt diet, tried exercise, steam showers. Then we had the pleasure of meeting, and he also had the pleasure of working with Dr. Loewenthal at the Osher Clinical Center, and was then referred for some other treatments. And notably, he had a lot of testing that was simply unremarkable, which is very common in people with post-COVID syndrome. At some point, which isn't listed on here, he did have episodes of chest pain and chest tightness along with his other symptoms. And so therefore, he also underwent coronary CTA to rule out coronary disease. I want to just highlight briefly another test that was done and can be done at home or with any provider if you are a clinician and the typical orthostatic measurements are negative, but you have a high clinical index of suspicion that a person has autonomic insufficiency or orthostasis. There is this test called the NASA lean test. And this was something that was mentioned by Marvin's physical therapist. This is done by doing 10 minutes of standing. And Marvin actually did this test at home on his own. And I'll just, in the interest of time, just briefly show you the graph here. And once again, it is reproduced that he has a significant drop in his blood pressure going from being in the supine position to the standing position. We have a diagnosis here, sort of. What do we do? And from the perspective of cardiovascular system, what we want to do is try to increase increase venous return, increase afterload for people who have orthostasis. And we can do this with medications. We can do this with exercise and other techniques. And for Marvin, he initially was started on fludrocortisone and also a medication called droxidopa. He really needed both of these medications to help control his symptoms, but it simply wasn't enough. He tried some of his own remedies as well, including cold therapy, which he's going to talk about a little bit. He really engaged in his own mind-body work and engaged in a meditation practice. And as you can see, all of these therapies had a significant impact on improvement in his symptoms. He was then, referred on for multidisciplinary care with Dr. Harrold because of his upper extremity symptoms of numbness and tingling. He had an MRI of a cervical spine, which showed some spinal stenosis, but thought not to be the etiology of his symptoms. He did ultimately have autonomic testing, which was consistent with small fiber neuropathy and was, markedly abnormal. And at that time, then he was started on pyridostigmine or mestinon. And that also helped, but did come with some GI side effects. He remains now on that continued cocktail of pyridostigmine, fludrocortisone, and droxidopa, all of which have completely resolved his symptoms, but not without the help of the other integrative practices that he engaged in. And he was also recently started on low-dose naltrexone, which has helped. Toward the winter, he also started acupuncture, which was paramount in resolving his tinnitus and some of his neuropathic symptoms. He also engaged in a device that led to vagus nerve stimulation, which he also found very helpful. And then most recently, he had continued to have some post-exertional malaise, which, as I mentioned, can really plague people with post-COVID syndrome. And there was some recent data suggesting that this supplements that target the mitochondrial complex, which consists of coenzyme Q10 and acetyl L-carnitine, can help with those symptoms. So he was started on this about 5 weeks ago, and his post-exertional malaise has now resolved completely. That being said, he had improved significantly by the time we started him on this cocktail, but now his symptoms have completely resolved. We won't go into the mechanism. If you're interested in learning more about why this happens, the reference is there. So in summary, before I turn it over to Marvin, we had a healthy 66-year-old gentleman who developed COVID-19 in January, which was complicated by persistent neuropathic symptoms, profound autonomic insufficiency, and post-exertional malaise. And his recovery, which occurred, and I am excited to let him talk to you about that, really required this multidisciplinary approach using integrative modalities. It wasn't just medications. It also included non-pharmacological interventions and supplements. And it was really those non-pharmacologic interventions that tied everything together and really brought him to recovery. So with that, I am excited to let you meet Marvin here, who is next to us. So Marvin, tell us a little bit about your journey. What was it like for you to navigate through this diagnosis? And just tell us about your journey.
Okay, good morning. I'm Marvin. And before I start the journey, I do want to thank all of my wonderful providers for providing and for letting me be here and talk, but also really for all the wonderful care that I've had from all of them. And it makes a huge difference. My journey, I was a retired engineer and I was a person who worked in construction on my own home here and on a summer cottage pretty much daily. I was a healthy man who was enjoying travel. And then during the course, and stayed out of trouble during COVID, I was the first in line to get all the inoculations in February of 2021 and March. And it was in January of 2022 that I came down with what I've come to understand is a mild to moderate case of COVID, but I was one of the earlier ones. People who got COVID after I did very seldom had the type of constellation of symptoms, but it was, quite frankly, a very scary experience. It changed my life. I went from being that active person to a person who had a very hard time just literally getting up, getting myself to do things, and being able to make it through a day without the excess fatigue to the point of an exhaustion. And it was a very difficult journey. But with the type of help that I got and trying different things, I got better slowly.
Yes, you did. Can you talk about what it was like just navigating the community with that diagnosis? You know, shared some experiences that you felt were unique to you as a quote unquote COVID-19 long hauler. So
Right.
could you talk a little bit about that?
So, well, I guess the thing is that COVID-19 is rather new. So there aren't, as I've come to understand, there aren't biomarkers. And there was, especially then, a lack of experience within the medical community of what exactly was going on and what to be able to tell a patient to do and what to expect. And obviously, my previous doctor tried to give me hope and gave me care, but didn't really know what to go to. And by just assessing my own symptoms and reading on the internet and speaking to knowledgeable people, I thought that I had POTS-like symptoms, but really still didn't know what to do with them. I think the thing that I'd like to say is that some people who have the same conditions as I did found that they got that they did not feel that their doctors were listening to them specifically, that they felt that they weren't being heard, that they weren't being validated, and that they were being told that you're young and you're healthy, and this is mostly possibly psychosomatic, but that it was a message that they didn't know how to deal with at a time at their younger lives, that they really didn't know where to go, and were extremely scared, and unfortunately still are.
Yeah. No, I want to just briefly also talk about the heightened sense of anxiety that occurred. And when I met you, you were in that state, and you know, as physicians, caregivers, and someone comes to us with this extreme anxiety, we don't know, we haven't met you in a state unlike that.
Right.
And so we're never sure, okay, is this really new, or is this something that's really been pervasive throughout their life? And I'm here to attest that this is completely resolved for you. You're a different person than I met 2 years ago. And so maybe if you could, especially for those who have gone through this, who are still feeling unheard, what was that like for you, not being an anxious person and then suddenly something changed internally?
It was horrible. And exactly as you said, I was a different person. Even to myself, I recognized that I honestly was experiencing things that I never had. And so I wasn't able to say, oh, I know what this is like. I'll get through this. It was it was extremely difficult, and it just compounded the illness, and the illness compounded the anxiety. And I started to understand how people can have this mind-body disconnection. And I specifically remember one night going to bed. I was alone in my cottage at 11 o'clock. My head was hurting. I was anxious, and I saw my pulse go down from 52 to 50 to 48 to 46. And I honestly didn't know what was going on. And I just said, look, go to bed. Hopefully tomorrow morning you'll get up. But what that translates to is the uncertainty already, with some anxiety already there, just got worse. It was a very difficult time. And it forced me to look for any possible way to find a way out of that cycle of anxiety that I really hadn't had to deal with before.
And you were initially started on an SSRI. You were started on Lexapro. Correct. And that had not much effect, maybe a little. Can you talk about what really helped? What were the interventions that made the biggest difference for you? Because I saw the transformation.
Right. Well, transformations can be slow sometimes, and but some of the things that did, like anybody else, I explored the internet. I questioned my professional friends, and breathing exercises and meditation exercises were amongst the first things that I tried. Then the other thing that I tried as part of, I was going for IV, um, uh, I was going for saline IV, very close by here. And part of the modalities that they have are compression and cryotherapy. So I tried the cryotherapy, which is standing in a booth in minus 165 Fahrenheit air for about just under 3 minutes. And I found that it really helped me. Would go to physical therapy, do very minor, simple exercises, but come out with headache, tingling, sweating, actually not sweating as much as feverish feeling, even though I had no fever. And the cryotherapy would help. But I went and explored more and read about Wim Hof and cold immersion. And I started doing my own version of cold immersion by taking cold showers and then cold dunks in a lake or in a cold hot tub or a cold tub. And I found the results remarkably instantaneous and just changed things like nothing else had changed them. So I just kept on that and have been doing that ever since, every single day, sometimes more than once a day, for the past 2 years.
And that has also contributed to reducing some of the doses of your medications as well, and controlling some of the symptoms of the orthostasis and autonomic insufficiency.
That's true. Yeah.
Can you describe, we have just another minute or so, and we'll turn it over to the next speaker, perhaps describe some of the other modalities that you used. You tried the alpha stim device and you had some acupuncture, and both of those, as you remember, were really critical in resolving some of the other neuropathic symptoms that you had.
Yes, I went to Katie Walker and did acupuncture and alpha stim, or if actually it wasn't called alpha stim, she'll tell us the right way, but it's a vagus nerve stimulation. And both had amazing, when I say amazing results, I remember lying down on the table telling her I had tinnitus, and with one needle put in the right place, I literally just felt it stop. And I had never felt it just go off as it did. But the big picture was Katie walked me through on a weekly basis we reviewed my case and found ways to help me. I ended up, after some number of weeks, stopping, actually a couple of months, stopping the acupuncture, but continued on for months and months and months with the vagus stimulation. And I found that it helped me a great deal.
Fantastic. All right. Well, it's always so nice to get the perspective of the person who's experiencing the ailment. And so we really appreciate you sharing with us and taking this time. And we will come back at the end for the panel discussion.
We'll turn it over to Dr. Harrold now.
Right, so I'm Kyle Harrold. I'm a neurologist at Brigham as well as Mass General, as previously mentioned, and I'm going to talk today about the neurological approach to the assessment and management of long COVID. I think it's important to acknowledge that, obviously there's been a lot of challenges with long COVID, as everyone attending today, I'm sure, is well aware, and I think that's typified by the fact that it's hard to get everyone to even agree on one single definition or term for long COVID, right? So these are some of the different terms that have been thrown about in the literature and in the lay press. I think the two, at least in the scientific literature, that seem to have had the most staying power recently are post-COVID condition and post-acute sequelae of SARS-CoV-2 or PASC. Similarly, it's been hard even to come up with a definition that everyone can agree upon. But the WHO in 2022 published this in Lancet Infectious Diseases, where they surveyed experts all over the world and came up with a consensus definition for post-COVID conditions. And the definition that they came up with is that these conditions occur in people with a history of probable or confirmed infection, usually 3 months from the onset of the infection, with symptoms lasting for at least 2 months, and importantly, that are not explained by an alternative diagnosis. The common symptoms that they highlighted in the definition include fatigue, shortness of breath, and cognitive dysfunction, though obviously this is not meant to be an exhaustive list by any stretch. And they make a comment that generally these symptoms have an impact on everyday functioning. And then the final point of the definition, which I think is also important, is that these symptoms can either be new in onset after a period of initial recovery, or that they can persist from the initial illness, and that these symptoms can also fluctuate or relapse over time, so that people really can have variable courses and still fall within this definition. And so, what are the symptoms that people have in terms of neurological symptoms? This is data from Igor Koralnik's group at Northwestern, where they initially published their first 100 patients, and that's the first visit column. And then they had 52 of those patients come back for follow-up at a median at 15 months. And you can see that in the second column. And you can see a lot of the symptoms are similar to the symptoms that we see, and I think that are most bothersome to people. So things like brain fog, numbness and tingling, headache, dizziness, and fatigue. And unfortunately, those symptoms, even at follow-up, didn't seem to be significantly improved at a period of 15 months. But there were some things that certainly did improve. So people, there was a significant improvement in the number of people who went from having more than 4 symptoms to fewer than 4 symptoms. Things like abnormal smell and taste did seem to improve with time, but unfortunately not everything, at least in this experience in Northwestern. Of course, COVID and long COVID affects more than just the nervous system, right? So this is a meta-analysis of 63 studies looking at various post-COVID syndromes that people can have in the different organ systems affected. I highlighted again just some of the neurological aspects that are common, things like effort intolerance or post-exertional malaise, as Marvin talked about. Fatigue is obviously very prominent and debilitating, and then things like difficulty with concentration or brain fog, cognitive issues, and headache also very common and debilitating for people. There's also been an effort to try to see, do these symptoms seem to cluster together? And so this is a group published this in JAMA last year, and they found that you can cluster patients into 4 symptom clusters. So there's one group of patients who really seem to just have smell and taste changes, but nothing beyond that. There's another cluster of patients who have really prominent post-exertional malaise and fatigue, but no prominent cognitive involvement. And then a third group who have the post-exertional malaise and fatigue, but with the addition of brain fog and cognitive issues. And then a fourth group who has all of those problems, but additionally has dizziness, GI syndromes, and palpitations, suggesting a component of dysautonomia perhaps in this fourth group. There's been a lot of work, of course, to try to figure out why this is happening to people. And the short answer is that unfortunately we still don't know. And if you just advance it by 1, the one thing that we do seem to be fairly confident in is that direct viral invasion of the virus into the central nervous system doesn't seem to be playing a major role. There's really been no compelling, convincing evidence that all of these other etiologies in combination of a little bit of each of these. So it's a multifactorial etiology. And I think that's also part of why it's been so difficult to find a treatment that kind of works for everyone, right? And for each person, it's probably different amounts of relative contributions. What do we do when we see someone in the neurology clinic with long COVID? I think one of the most important things we can do actually is make sure we're not missing something else. So everyone gets a very thorough neurological history and exam, both to quantify and qualify the problems from long COVID, but also to make sure there's nothing else that's contributing that would be easily treatable. I think the MOCA, or the Montreal Cognitive Assessment, is a useful tool to screen everyone for cognitive impairment. I think a basic set of labs, just again, mostly looking for something else that's easily treatable, is important to do. And then I explained to everyone that unfortunately there's still no clinically or commercially available biomarker for post-COVID conditions. So it's really a clinical diagnosis still at this point. Other things that we consider would be an MRI if there's any concern for a structural process, although, as previously mentioned, MRIs are typically normal in people with long COVID. I have a very low threshold to refer people for a sleep study, especially if they have fatigue and if there's any concern for obstructive sleep apnea or any other sleep disorder. Neuropsychological testing, I think, can be very helpful for people with cognitive concerns, both because it helps to qualify and quantify the degree of cognitive impairments, but also because the neuropsychologists are really excellent and very thoughtful and provide people with personalized feedback and recommendations on how to work around their deficits and really maximize their strengths. Mood disorder screening, I think, is important, not because it's necessarily the primary driver of the syndrome, but because anyone living with a chronic illness is at risk for anxiety and depression. And I think treating that as a secondary problem, if it's present, is certainly important. And then finally, autonomic testing, if there's any concern for dysautonomia. So things like lightheadedness with standing, as we heard from Marvin, GI symptoms, GU symptoms, or any other autonomic involvement. Autonomic testing can be helpful. This is actually Marvin's autonomic testing results. And so you can see the 4 components, and we'll go through them briefly. So the first component is just monitoring someone's heart rate as they do deep breathing, and what you expect to see is heart rate variability, as the heart rate should change with inspiration versus expiration. And Marvin did have slightly reduced heart rate variability. The next component is a Valsalva maneuver. They have someone bear down and measure their blood pressure, and there should be a typical blood pressure changes as someone goes through this maneuver, and Marvin's were normal. And then the third component is the tilt study. So this is basically like a more formal version of the orthostatic vital signs that Dr. Parks had mentioned earlier. So they have someone lay down on the table for 5 minutes while they measure their heart rate and blood pressure, and then elevate the patient to a 70-degree heads-up tilt position. And you can see Marvin's blood pressure started between 130 and 135, and then there was an abrupt drop to 65 millimeters of mercury for about 5 minutes, and he actually lost consciousness. This was clearly a very positive and abnormal test result. And then consistent with the data that he had already shown us from home. And then the final component is this quantitative sweat test. So they measure sweat production from various sites. In Marvin's case, 2 of the 4 sites measured had abnormal sweat production. So altogether, this was thought to be an abnormal study, reflecting dysfunction of both the parasympathetic and sympathetic divisions of the autonomic nervous system. So what can we offer people with long COVID? I think one of the most important things, and Marvin alluded to this too, is just to validate people's experience, right? I think so many people come to the clinic and say, nobody believes me, or people tell me it's all in my head, or there's nothing that can be done, or that I'm just crazy. And certainly none of those things are true, right? This is very real, and there are a lot of things that we can offer people. I think for everyone, certainly counseling about diet, exercise is able, and sleep, right? Those things really can make a big difference. For people with a pastoral orthostatic tachycardia syndrome or dysautonomia phenotype, counseling about increasing salt and fluid intake is important. Things like compression stockings and abdominal binders can make a big difference, although, to be honest, are often not very well tolerated. For brain fog, cognitive therapy via speech language pathology can be very helpful to people. And I already talked about the neuropsychological testing and the recommendations the neuropsychologists provide at the end of the testing. For headache, there's a lot of lifestyle interventions that can be really useful in complementing the pharmacologic interventions. And then finally, for post-exertional malaise, which is probably the most debilitating symptom for many patients, there's this 4P approach. So planning out your day, prioritizing what you have to do throughout the day, pacing to try to meet those goals, and then positioning to really optimize the ergonomics and make it easier to accomplish what you need to do is a useful framework. And then also counsel people on graded exercise. I think many people come to clinic and say, oh, someone told me to exercise, I tried and I felt terrible, which is predictable. That's part of the post-exertional malaise syndrome. What I tell people is to find something that they know won't push them over the threshold of becoming symptomatic, even if it's something really, really simple, it seems silly, and then to increase that really slowly over time, increasing again in really baby steps. That increments again are so small that they seem silly, and to increase very, very slowly with these very tiny increments. And I find that people are more successful with that approach. In terms of pharmacologic interventions for POTS or dysautonomia phenotype, so we talked about some of these already. because Marvin has used some of them. So pyridostigmine is one that I find that tends to be relatively well tolerated, although it can have GI side effects, as Marvin experienced. And the way that it works is it increases the amount of acetylcholine at the neuromuscular junction, or at the ganglionic junctions, and it enhances both parasympathetic and ganglionic sympathetic transmission. Beta blockers can be useful specifically for people with the POTS phenotype because it blunts the tachycardic response to standing. Fludrocortisone increases the amount of sodium uptake in the kidneys and it expands intravascular volume. And then midodrine and droxidopa both increase vascular tone. It can be very useful as well. They do have this boxed warning for supine hypertension that's mentioning. So you have to be a little bit careful with those two. And then these are other interventions that I think there's a lot of interest in. Stimulants certainly have anecdotally been useful to some patients. There's really no compelling clinical trial data that they work. As a kind of corollary, there have been trials in chronic fatigue syndrome where there really hasn't, again, been any compelling evidence of benefit when compared to placebo. IVIG, I think, is something that there's a lot of interest in as well. In terms of long COVID, it's only been assessed in small, non-randomized settings without a placebo control. And again, just extrapolating from the chronic fatigue syndrome literature, there were controlled trials which were negative. And it's unfortunately expensive. It's a limited resource, and there's significant potential for adverse effects. So it's something that I would be very hesitant to use, except in very particular circumstances. And then finally, low-dose naltrexone, I think, is a really interesting intervention that has a lot of emerging evidence of clinical benefit, is likely very safe. But I think the story is still being told, and kind of evidence, as I said, is still emerging. And the mechanism is that's thought to be immunomodulatory at low doses. And again, certainly anecdotally, there's some people who have found it very useful. But just to summarize briefly, post-COVID conditions are common, diverse, and debilitating, likely are multifactorial in etiology. The workup must include exclusion of other contributors. There's no post-COVID specific treatments there's no post-COVID specific treatments available, but many interventions are available. And non-pharmacologic interventions are at least as important as pharmacologic interventions. And with that, I will turn it over to Katie Walker.
Hi, thank you. So from a fundamental perspective, we're looking from an acupuncture lens to treat the individual and not the disease. So I might see several patients with long COVID, but I'm looking at their unique presentation. And to do that, I tease out a bunch of different symptoms, including their main complaint, to get a sense of what the different body systems are telling us. And this tells us a dynamic relationship between these symptoms that allows us to understand the pathophysiology of how their body uniquely responded to the disease or the stressor. During this information gathering process, I'm looking at the patient's stature, looking at or listening to their voice, taking into account even their personality. And I'm also using 2 diagnostic measures, taking a look at the tongue and feeling their pulse. These are considered microsystems of the body, and they assess internal organ movement as well as physiology of those internal organs and the movement of blood and fluids within the body. Then we also do some palpation. I might palpate their abdomen, palpate the channels. We're looking for tension and blockages within those channels, as well as the feeling of the tissue and temperature itself. So when a pathogen like COVID comes into the body, in Chinese medicine, we're looking at this as a heat response. And this heat response is looking to expel the pathogen. So this heat is actually pulled from the lower body, and it's sent to the surface in order to generate a fever and sweat. And then the fluids are also diverted from the digestive system to help contain the pathogen through mucus production. So during this process, resources in the body become pretty depleted. And so the aftermath results in sort of a dryness and a heat syndrome. And so we see dryness of the blood, and you might see issues with orthostatic hypointolerance, where you're getting this dysautonomia symptoms. You might see residual dryness of the mouth, sore throat. And we also see dryness in the tissue. So we might see a stiffness as well. And so putting this all together, we're sort of getting these symptoms on the left that you see in red. So in cases where there's this cold deficiency in the lower body preceding this infection, as is the case that Marvin had some of these symptoms of hypothyroidism, chronic pelvic pain, and GERD, I take those all into account when I'm thinking about his case. And so in this case, we had this blockage in the lower abdomen. The heat was actually unable to come down to where it needed to go in the digestive system. And then that cold couldn't ascend to relieve his heat symptoms that he had above. And his tongue and his pulse really reflected this as well. So his tongue was very red. It was slightly deviated, which is a sign of neurological imbalance within the body. And it was puffy with a white patch on the tongue coat, which is a sign that the fluids weren't moving properly in his body. And it was also depressed at the root, which is a sign of deficiency in the lower body. His pulse was also deficient in the digestive organs, which is the middle pulse, as well as within the lungs. And then his pulse was slow overall, which is a sign of cold in the body. So again, this cold cannot allow things to be moving properly. Okay, so our treatment is essentially aiming to restore this dynamic movement within the body. So we want to unblock that cold that's coming across the middle. We want to send that heat that's above back down. And then we want to send that cooler energy. And so the points I used were really trying to move that energy in that direction. It's also important to note I didn't use all these points at the same time. Patients with dysautonomia tend to be overstimulated if we use too many points. And so that can trigger their dysautonomia symptoms. Also, the goal of acupuncture is to move the patient into this parasympathetic state of rest and digest. And a lot of patients actually fall asleep while they're on the table. And the other tool that I used to kind of move his body efficiently into that state was that vagus nerve stimulator, which I'll talk about more in a second. So how does this work? So on a fundamental level, acupuncture can simultaneously engage both the immune system and the nervous system. So when you put a needle into the body, it creates this micro trauma in the tissue that breaks open mast cells. We see release of adenosine and histamines. We get increased levels of nitric oxide, which is a vasodilator. So we basically create this like local inflammatory response within the tissue. And then peripheral nerves are stimulated. That sends messages into the central nervous system. And so we see global effects within the spinal cord and within the brain through the release of neurotransmitters, neuropeptides, and hormones. So one really studied pathway that acupuncture exerts its global effects is through this vagus nerve. And the vagus nerve is like this two-way road where we get information from the internal organs into the brain. And then the brain also regulates that internal organ function by sending messages back down into the internal organs to regulate that rest and digest function. So in cases of stress or a pathogen like COVID, the body generates this sympathetic sort of fight or flight response because it's in survival mode. And so resources that would normally go to digestion and rest and repair, they're sort of diverted and they're put on hold. And so that results in this dampening of parasympathetic function. And so briefly, just some research has indicated that points on the limbs can initiate, and you can see on the right here in this mouse model, can initiate this vagal adrenal anti-inflammatory axis depending upon the type of stimulation that you're doing, whereas points on the torso tend to engage the sympathetic reflexes according to which nerve root is activated. And depending upon the location and the depth of needling and the intensity, you might have a pro or anti-inflammatory effect. And then just briefly to talk about the vagus nerve. So one of the main branches of the vagus nerve is actually located in the ear, and it's the only branch that you can access on the surface of the body. And acupuncture within the ear is predicated on this concept. And if you look on the left side, you see some green that demarks the auricular branch of the vagus nerve. And we have this somatotopic correlation between this auricular branch, the vagus nerve, and the internal organ system of where we would put a needle if we were going to needle and have an effect on that particular organ. And functional MRI research indicates that there is this somatotopic correspondence within the brain itself. So if you stimulate the ear on the thumb point, it has a similar reaction within the brain as if you just push the thumb itself. So all that to say, stimulation of this region of this internal portion of the ear with electrodes facilitates this parasympathetic response by stimulating this region of the brainstem called the nucleus solitary tract. And so with that, we see changes in breathing, respiratory rate, we see changes in heart rate, we see changes in peristalsis. So all of these rest and digest functions. And then just briefly, nucleus solitary tract also connects into these regions that are responsible for norepinephrine and serotonin release. And these are neurotransmitters that are really important pathways for pain, especially headache, and also for anxiety and depression. So they also make the vagus nerve a really great target if we're looking at a stress response to this dysautonomia. So I'll just briefly mention, Marvin already talked about his response, but he had a great response with acupuncture, particularly within the first 6 treatments. He was able to taper his fludrocortisone. You can see all the symptoms that he listed that were improved during that time. Then I think, as mentioned before, he did stop the fludrocortisone for 2 weeks while he got his COVID booster, so he could mount a really good immune response. But then he had some worsening of symptoms. We continued with treatment. And in the end, he really noticed a marked improvement in his quality of life. And as he mentioned, he continued with the vagus nerve stimulator beyond that. So take it away, Julia.
That was great. So I'm just going to highlight a couple of key points about the cold exposure aspect. So again, I'm a geriatrician and internist at the Osher Clinical Center, and I met Marvin kind of in the summer of the first year he was having symptoms. And so he actually embarked on cold exposure via cryotherapy, which he talked about, which is standing in this sort of cold, foggy air. So that's that image on the right there. Cold exposure can also be done through cold water immersion. So things like polar plunges or ice swimming, or just exposing oneself to cold air. So there are different ways to get this type of exposure. This is called voluntary cold exposure. It's a tradition in multiple different cultures. So for example, in a lot of Scandinavian countries, there's a strong tradition of ice swimming. And oftentimes people will alternate the cold with the heat for different health effects. And that's usually done with, things like sauna exposure. Cold water immersion has, so there, just to say as a caveat, there are very few kind of standard definitions of this in research right now, but cold water immersion is generally defined as an immersion in water that's as warm as 68 degrees Fahrenheit. So that's what's considered cold. I just want to, so what we're looking for with cold exposure is a cold stress. So we want to, have people really maintain a normal mental status. We want to try to stop it before we're shivering a lot, because there's a really easy threshold where you can get into different stages of hypothermia. So just to say as a sort of cautionary point that, we really want people to generally stop the cold exposure once they're shivering. And there's a lot of adverse effects that can come from cold water immersion in particular. I just wanted to highlight this because there's a lot of cold exposure stuff on social media right now, and I think we don't hear a lot about the downsides. So just to say that cardiac arrhythmias are a big problem, especially in the first 1 or 2 minutes of cold exposure. And so if we have somebody who has a history of cardiac disease, this is something you'd want to talk to your doctor about or avoid altogether. And just some tips, if you are thinking about trying this, definitely don't do it alone and have a plan for calling 911. And you want to try to think about acclimating slowly to start with. So I'll highlight now some of the therapeutic effects. And again, just showing when Marvin tried this back in 2022, starting with cryotherapy and then moving into cold water immersion. So some of the acute effects are thought to be mediated by activation of the sympathetic nervous system. This is increasing circulating catecholamines like norepinephrine, epinephrine, and dopamine. And this might account for some of the acute effects that Marvin noticed, where blood pressure is raised as a result, and it can help sort of counter that dysautonomia aspect. From regular cold exposure, so where people have repeated exposure to cold over time and they have a period of adaptation and acclimation, there are other potential beneficial effects. So one being shifting the response of the nervous system into a parasympathetic response. So bringing on what Dr. Walker described as sort of rest and digest stages, and also some immunomodulatory effects, as you can see listed in this diagram. And clinically, cold exposure is thought to be helpful for reducing pain from various types of arthritis. improving recovery after exercise, and also improving mood. There's very little research in long COVID. There's really just case reports available in the literature, but thought to be some helpful potential benefits in terms of mood, fatigue, and also potential adaptation to stress over time. So because of the time here, I'm just going to end on this slide, which is that cold exposure is a potential way to adapt to stress and build resilience through this process of hormesis. And so that's potentially, I think, part of what was contributing to Marvin's recovery, along with everything else he was taking advantage of, was really improving his resilience and helping his body to heal. So I will go ahead and end there. And I just want to thank all of our wonderful speakers, and especially we're grateful to Marvin for sharing his experience here in this public forum. And I think we have a minute or two for questions.
Thank you. We tried to answer each of the questions in the chat box. There are a couple that are left. There was one question about the use of low-dose naltrexone. So Dr. Harrold, you want to just chime in briefly? I know you mentioned it on your slide, perhaps expand.
Yeah, I think, my understanding, I wouldn't consider myself an expert in low-dose naltrexone, but is that the presumed mechanism through which it seems to be helpful to some people is through this immunomodulatory effect that it has at low doses. But as far as I understand, actually the exact mechanism is still being figured out. So that's not a satisfying answer, but that's my understanding of where we are.
Very few side effects as well, and low risk to the patient. It does have to be acquired from a compounding pharmacy that can give you the micro doses for that.
Well, I know we are right at time, and I just wanted to first of all thank Marvin for just such a for your courage, for sharing your journey with us, and thank just really, it was so much learning here. Thank you to all of you for what a stimulating presentation, and thank you for answering the questions. I know we got to a lot of the questions through the chat, so thank you, Kim and others for doing that. What a beautiful panel. We hope to have a round 2 of this to see the continued journey of recovery down the road. If you would allow that, Marvin, we would love to have you come back and see how this continues. And by that time, perhaps we'll know more. Obviously, this is such an emerging condition that we're still learning so much about. Just really quickly, I wanted to just again remind everyone to get your CME credit. Please email us. Then save the date, December 9th and 10th. This is where you can have more of these types of dialogues. Please come. And so put it on your calendar now. And finally, come next month. We'll have another extremely powerful presentation that I know all of our presenters, or many of our presenters here know Beth Frades quite well. So come back for that. It's going to really be a amazing dialogue. So thank you everyone for being here. We had a wonderful turnout of more than 200 people here. So this is what a stimulating grand rounds. Thank you. And look forward to seeing you next time. Be well, everyone.